Happy 2020 from First Bite and SpeechTherapyPD.com. We wanted to announce that to kick off 2020 for the first time ever, we will be issuing out, and wait for it, drumroll, dun 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 dun, an all-new Podcore subscription. For $79 a month, you get over 175 hours of ASHA continuing education with 19 new episodes a month. That's fantastic. Well, they want to make sure that you also know we have a brand new coupon code. So the coupon code is F as in first, B as in bite, followed by the number 20, FB20. And that brand new coupon code will give you $20 off the Podcore subscription. So you get 175 hours of continuing ed plus an average of 19 new hours a month, all for $59 a year. And we cover everything from early intervention to schools to adults to ethics. So be sure to type in F as in first, B as in bite, and then the number's 20. Enjoy your coupon, or as my kinfolk say, enjoy that coupon. Hi, folks, and welcome to First Bite, fed, fun, functional resources for the pediatric clinician. I am your host on this nerd venture, Michelle Dawson, MS, CCC, SLP, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention, right there with you. I run my own private practice, Heartwood Speech Therapy, in Coletown, South Carolina, and guest lecture nationwide on best practices for early intervention for the medically fragile child. First Bite's mission is short and sweet, to bring light and hope to the world for the pediatric clinician, parent, or advocate. In this podcast, we cover everything from AAC to breastfeeding, best practice for running a private practice, and all the nitty-gritty details involving feeding and swallowing by interviewing the subject matter experts themselves. We bring the data to you. Every fourth episode, I am joined by the lovely Erin Forward, MSP, CF, SLP, a Yankee transplant who actually inspired this journey and who also walks the wild, woolly, and sometimes sticky walk of early intervention with us. Sit back, relax, and watch out for all the squirrels, and enjoy this geeky gig brought to you by SpeechTherapyPD.com. So today's episode falls in the fed, fun, and functional categories. And on a personal level, I hope it lifts away the wintertime blues and brings some sunshine straight into your soul. Because today we have two lovely folks back who have filled my personal and professional cup several times over. And I am all about spreading joy and hope when and where we can. So I'm grateful that they came back so that they can refill your cup too. So on that note, as I'm Southern and a firm believer in ladies first, not just because I want a head start in tic-tac-toe with the goose and the bear because they cheat, but let me introduce the lady, the dynamic Elizabeth Beth Halpin. Did I say it right or did I bad English that? MHS OTRL SCFES from episode number 60, Ots and Feeding. Who knew? And the awesome Rob Dempster, PhD, who's a pediatric psychologist from episode number 71, Psyched about psychology and feeding. Now, these two fabulous folks are not only colleagues in the grand sense of the concept of we all work together for pediatric feeding and swallowing, but they are also co-workers in the very real sense that they work together in the same building, troubleshooting over coffee for the same patients to get them set for success. And I happen to know right this very second are sharing one set of earphones in order to pull off this fabulous recording. So go team. But this right here, that depth of interprofessional collaboration, that's the part that makes me so stupid excited about today. Because you know how when you find a rhythm with that coworker, that beautiful sweet spot of shared joint memory, Well, it's that amazing spot where joy and healing can actually start happening. So today, these two folks are going to share how that amazing thing happened for them and their team when they started working collaboratively for a combined treatment approach for pediatric feeding and swallowing disorders. So, Beth and Rob, yay! Thank you for coming back.
Yeah, we're thrilled to be here.
Thanks for having us.
Yay! Also, folks, if you didn't see it, I totally saved this profile picture of me recording on the bedroom floor due to acoustics and my kitchen being still a hot mess, and the lovely Beth and Rob pulling off a shared microphone earbud adventure. So we are all warm and cozy today, right?
That's true.
Amen.
Okay. All right. So we have a lot to cover, but in case folks haven't caught episode 60 or episode 71 yet, Beth, can you super briefly crash course us on who you are and a little bit about what it is that you do on a Monday through Friday as an OT?
Sure. So I work in our intensive feeding program along with Rob. And so, kind of Monday through Friday, right now, I am seeing two patients for 3 meals a day, Monday through Friday for 6 to 8 weeks. And so that is pretty much what I am doing um, Monday through Friday.
Okay. And you work with Sir Rob, correct?
Yes, I do.
I like this sir thing. I got an upgrade. All right.
I mean, who needs a PhD when you can have a Sir? Just saying.
Absolutely.
That's if only it were that easy, right? Okay, now what do you do Monday through Friday, friend?
So, well, my role with our intensive patients is working on the behavior plan. A lot of our families are not used to using behavioral strategies and applying them along with the oral motor strategies and everything else they're doing with our program. So, I have more patients because Beth is kind of in the weeds, in the meals day in and day out, whereas I'm behind the scenes meeting with them to see how they're adjusting to the plans, working with them on adapting it. But then also I see feeding outpatients as well, follow-ups from our intensive program, and also some consultation on the inpatient side of things. So we can kind of speak at it from all angles today.
Perfect. Okay, well that's good because we got a lot of ground to cover. Um and it is for lack of a better phrase somewhat this is territorial. Today's episode is territorial. I'm trying to find a PC way of segueing that, but there's no PC way. Let's just put it out there. SLPs, for the most part, like to think that feeding is our baby. And when we find out that OTs and psychs, and God help them if an RD tries to get in the mix, much less a PT, like it's like a little pissing war contest gets started. And but I am old enough and gray enough and have enough experience in my personal triangle of the evidence-based practice triangle to recognize that I need y'all, that we as a profession need y'all. So, that being said, there's all these misconceptions. So please tell us, for everybody listening, what does a combined treatment approach look like?
You want to start
Dun,
off?
Yeah,
dun,
you can start.
Well,
and then there were
so,
crickets.
so I guess at our center, like we'll be talking things mostly from the therapy and psychology end here, but where we are also the OTs and SLPs are considered feeding therapists. So half of our staff of feeding therapists are OTs, half are SLPs, and have the same duties and roles and everything here. So we really try to eliminate that turfiness, but also since even though we're talking mostly about psychology and therapy, really we have a combined treatment approach with the RDs, the MDs, social work, our chef, kind of the works with everybody here. So we'll focus on the therapy and psychology part though. So I think for us, it's really looking at two sides of the same coin. So being a psychologist, I got in-depth training in mood regulation, behavior management, all of those kinds of things. But if it comes to something like evaluating how somebody is swallowing or trying to look at texture grading or how they're able to build that skill, I'm really out of my wheelhouse. So the first year that I was here, I would be combined in our evaluation clinic with these other disciplines, but then kind of more on an island when I was in my outpatient treatment. This was long before our intensive program, and so when we started treating patients together, it was really figuring out that you talked about kind of a dance in the beginning of okay, which parts are more your part, which parts are more my part, and then there's also a lot of overlap in the Venn diagram, and how do we kind of navigate that stuff? So, I think that's what I think about the most with our combined approach is kind of making sure that we're working on a plan um, for the family at the same time, so they're not having to see two different people and try to pick out what they should be doing. We're able to help them with that collaboration.
And just to kind of add in from a therapy standpoint, so I mean, speaking from an OT standpoint, we're working on the oral motor skills and stuff, but so many times there were also behavior components that played into that. And, I mean, I knew some behavioral strategies, but by all means, I wasn't an expert in behavioral strategies and how to implement that and what that looked like at a mealtime and stuff. And that's where I relied heavily because I was totally out of my wheelhouse. Where I relied heavily on Rob to be able to add that piece to the puzzle. I could work on the oral motor and say we need to do these exercises, but if I couldn't get the kid to cooperate to do those exercises, I'm not going to make gains. And so that's where having that combined approach together, kind of all working on that same goal of getting that kid to eat, but coming at it from our respective sides and how do we mesh that together to work for the family.
Okay, I have 14 different questions. So let's start with the easy ones. Do you have a PT on the team?
No.
So who does positioning?
The OTs for the most part do the positioning, but really, like Rob said, we try to give the training for at least for our intensive for all of the therapists to be able to look at from positioning. But the positioning, if you want to break it down, would fall under OT.
See, that's a huge misconception. Because I've had parents say, well, the PT should be working on the sitting. And I'm like, oh, actually, I think the OT does that. And then I know out in California, there was a big push by the PT Lobbying Association that the physical therapists were supposed to do all feeding and swallowing, which is, yeah. Oh, yeah. Yeah.
Yeah.
I don't know what you think. I think most of our PTs are like, you go ahead and
Yeah.
keep them.
Right, yeah. And
know.
most of my PT friends do say that. You can teach them to feed and you
Yes,
can toilet them.
I'm just thinking, I don't know
So,
too many PTs that are lining up to do aggressive
no.
oral
Any of
care.
the ADLs
Yeah.
as far as
Yeah.
right, like the shower, the bathing, the toileting, the feeding, you can keep all of that
Oh
OT.
my God. So, to all the PTs out there, we love you.
Absolutely. So at least in our center here, so PTs by all means are an important piece of the puzzle for a lot of our kids because as we all know that trunk support
Mhm.
is a vital part of feeding, and the more trunk support and head control that you have, um, that just helps. It helps things move. It helps you when you get up and get moving, things to move through the intestines and stuff. So by all means,
Mhm.
PTs have a valuable piece, overall from a developmental kind of standpoint. But oftentimes, at least in my experience, is the PTs are looking things from a positional standpoint from a functional mobility.
Mhm.
Um, and so they're looking at what the proper wheelchair is for them to be able to support, to be able to get out into the community. And but we're looking at it more not so much from a general stability. We're looking at it specifically for feeding, and I think that's where, at least in my opinion, the OT is a vital piece for that positioning part.
And I think that's a big part of what changed for me with the co-treatment. I mean, my setup over in psychology had basically a regular chair, a small chair, or a giant chair, and trying to pick which one was sort of eyeballing and guessing and going for it. So once we started working together on these things, I really learned how important that stuff is, and really, so many of our patients, once they're not having to focus on how they're holding themselves up and they have that comfortable positioning, a
Mhm.
lot of their behaviors improve, right? So all these aspects kind of go back and forth with each
Okay.
other.
So that was my easy question, but there was a follow-up, but now that we've gone a different way, like, I've already forgotten the follow-up question. I need to start writing these down. Okay. So, Rob, I know we spent time talking in our last one about getting the parent buy-in. Um, okay. I'm trying to not jump the gun and slip down to like the third and fourth question, but when it comes to picking out the right patient for the feeding clinic, um, do you guys have parameters? Do they have to have an outside OT, PT, SLP, psych eval and consult before they come to you guys, or can they just be like a new patient altogether? Am I explaining that well? I don't think I can that.
Yeah.
Yeah.
Okay.
So for our center, our team eval clinic is kind of the funnel everybody has to
Okay.
go through. So that includes a feeding therapist, psychology, a medical doctor, a dietitian, and a social worker. So if they're being seen for one of these programs, they're kind of evaluated at that point by everybody at some point. So usually they're just referred by their pediatrician. But I'll say, before we were in the intensive program and all that kind of stuff, we would often do combined treatment approaches on the outpatient side. So Beth and I were routinely, I'd pop over to clinical therapies or she'd come over to psychology. And not necessarily for people who'd been done for that approach. And I guess the reason why I mentioned that is I feel like sometimes when we talk about this kind of thing, people are like, "Oh, that's great," in a large hospital system or whatever it is. But really, we started doing more co-treatment just by calling each other and popping over to an office and figuring it out. Having all the other stuff is great, but that's not the way that it has to be in order to help these families really navigate this.
Was it like an organic evolution? Is that how this went from like a co-treatment popping into like actually creating the clinic and like the consistent combined treatment programs? Was it just like organic, or did somebody like how did that evolution happen? Because we need that in the South and I really, really, really want that to happen in South Carolina. But like how?
So I think the answer is kind of complex. I would think. So I think the simple answer is that some of it happened organically. In the sense that we were both in a clinic, or I was seeing some patients that I was like, hey, I have this going on. Can I pick your brain a little bit? And then some of like as far as the intensive program goes, and really having all of the team members. Um, that was something the hospital had a desire to pursue, and so like the coach treatments just between OT and psychology, like I said, kind of happened kind of just more naturally of just getting it to know each other's approach to treatment in general with feeding, and then like I said, the intensive part was driven by the hospital.
Yeah, and they recruited our medical director here, who had been in a real transdisciplinary program, and so it's kind of these things were starting up, but then that just poured gasoline on the fire, and then you bring in somebody who's been there and has done it, and that just really sent it off.
That's awesome because we don't have it here. Like, I mean, heavens to Betsy's, that's how I met y'all, was because I was so concerned about that patient who, by the way, is eating Cheerios. Be still my heart.
Yeah.
I mean,
Wow.
we went from a year and 6 months ago to he wouldn't touch food, and now he is feeding himself almost all of his meals at school and, like, a fair few of them at home, and has started asking for a food pop and popping Cheerios in his mouth, and I'm like, "Oh!" So the advice that you guys gave
That's
was really
awesome.
good, and, Yeah, mom's happy. She sent me happy tear text message, and I'm like, this is so cool. This is how you do it. Yay.
That's what it's all about.
Yes.
Those
Yeah.
are the best messages
Amen.
to
I mean,
receive.
and folks, please don't think that I always have it together, because I definitely gave him a cracker one time, totally forgetting the kid was gluten-free. And then his mom was like, you rock. I was like, I suck. But, you know, we all sin.
As long as you own it, you know.
Right?
I owned it. And his twin sister looked at me and she was like, I think we made a bad choice. I was like, girlfriend, you are correct. Oh my God. That's great. No anaphylactic shock. We're okay. Okay.
Whew.
So yeah, right. Whew. At least it wasn't nuts. I did check myself there.
Right.
Okay. So, all right. So I'm imagining that when like a kiddo comes in. All right. So here's big picture, some thoughts that are running through my head. I have a couple kiddos that I would love to send to an intensive feeding program. I would love to send to a combined treatment program. But I feel like, and correct me if I'm wrong, I feel like several of the patients that I see just aren't medically stable because we don't have a full grasp of the underlying etiology. So like one case in particular, the baby has a rare genetic condition. We just finished tapering down from 17.5 milligrams or mLs of phenobarbital twice a day to once a day to nothing. And that's been like a 4-month taper. And we have complete feeding tube dependency. There was force feeding. There was a lot of other things going on, but we have signs, symptoms of feeding tube dependency. But at the same time, we still don't have the BMI in order to do the classic feeding tube dependency protocol of like cutting out feeding tubes.
Well,
like,
I guess if
yeah,
maybe I'll step onto a soapbox real quick. So,
Yeah.
because I think that's not necessarily how all intensive feeding programs work. And so I think that's the
okay, well then tell me, because that's my worry. I want her to come to you guys. I want several of my patients to come to you guys, but like, I don't even think that they're medically stable enough yet to do it.
So it really depends, so when we were building this program, like I said, our medical director had come from a program she had established, but we also went and toured other programs around the country to find out what they do and, try to pull in
Yeah.
ideas for what we do. And tube weaning is just one of the most fascinating things because, there's some programs out there like No Tube that'll swear you have to do rapid cuts. And there's inpatient programs that might cut 50% on the first day. But a
Yes.
program like that,
Those are the ones I know about.
yeah, so a program like that, you can't get into unless your body's above something like the 25th percentile from the get-go,
Yeah.
right? But then other programs that we visited would maybe do a 10% cut and see if that would help stimulate appetite, and then go from there. Really, for us, we don't do cuts on day one. We do one-to-one tube weaning. So for our program, we get our dietitians calculate what their body needs. We try to get them on daytime feeds or bolus feeds, to get them to be able to tolerate meals. And then whatever they don't take at a meal, they subtract out. And it's interesting when you go to each program, everybody thinks that, well, this is the way that you have to do it. And there's no randomized studies. We don't know what the most effective way of tube weaning is. But what I can tell you is their programs and our program all has success. So, we need to have more research on it, but my guess is they're like the kind of kid that fits in a rapid program is going to have that stable weight. But we have kids who come to our program because even on tube feedings, maybe the family has an intellectual disability, or maybe their cultural practices are just so, not akin to all of these tube feeding numbers that they haven't been able to wrap their minds around exactly how to do the different schedule. But once they're here on a day in, day out basis, they're able to gain the weight. So the weight gain might be something that's needed for certain programs, but not necessarily every program. And I think,
I had no idea. Okay.
yeah, absolutely. And so, a lot of the ones that do the rapid weaning tend to be more inpatient because we can't do a rapid wean without being able to monitor levels and things like that. But a lot more of the day treatment ones might be able to take that. So, but I think the thing that's important is really to talk to the specific programs and find out what their approach is and how that fits with the patient that you have. There are some patients who, if they are on continuous J tube feeds for 20 hours a day and their body can't just tolerate any more food in their stomach, they probably aren't going to be a fantastic candidate, right? But if it's more just maybe they're a 0% oral eater, but they're able to take bolus feeds, they're not having vomiting with every single feed or anything like that, then we see many of those kids.
Okay, so what about the ones that don't have an etiology yet? Like we're assuming GI components like delayed gastric emptying or delayed GI motility or stuff like that. Do they have to have those diagnoses in place before they can be successful in a combined treatment program, or do you guys work with them through that? That's what I mean.
We don't need the etiology, Michelle. We can work with them and through that. That's the advantage of having such a large dynamic team, is that we all kind of bring that piece to the puzzle. And so usually we rely obviously on our medical director to be able to, look at it, and she might prescribe a medication, or we might look at it and say we're going to just only limit volumes to a certain amount, and kind of gradually move up from that. But we do not need to have um, a set understanding of why things are happening.
And I'd say most of the time there's
Mhm.
not a smoking gun.
That's
Like
true.
we don't know, and waiting to figure that out. I mean, now don't get me wrong, we want to make sure the appropriate tests have been run. What if there's eosinophilic esophagitis? I mean, that's more of our medical team could talk about, all of that stuff. But the bottom line is a lot of the time you just don't know why.
Right.
Go ahead.
And oftentimes with those kids, we start with such gradual exposure to things, so that if we do get some sort of reaction or, kind of to it, we're able to narrow it down to that specific food or formula that, because we don't make a bunch of changes, kind of all at one time when we do start introducing things orally.
But by the time they've made it to us, usually they've done every test under the
Yeah.
sun. Is the bottom line, and I've had close personal friends that have had to go through this type of program where their child just stopped eating. They ran every single test. No, developmental delays, no nothing. And they just don't know why. We never did, but he got that nasal feeding tube out and he's doing great,
Oh, bless their little souls. That's the worst feeding tube possible. In my opinion, because I mean, I've had kids get tangled up in it and like rip it out and
You
just,
know what though? I think
that hurts my mom.
I get the it's hard to see, it's hard to watch, but for a lot of our kids, what happens, think particularly about like our inpatient consultations, they get admitted for having low weight, and behavioral strategies will initially make it so that you don't eat as much while we're changing things up. So if there's not a safety net, that's fine if you're at a good weight, but for our kids who are admitted to failure to thrive, for a lot of them, if it wasn't for having an NG tube temporarily, they wouldn't be able. They what they would have is a permanent G tube.
Okay.
But go ahead.
No, I was going to share Erin, my sweet Erin, who co-hosts this with me, right? She had the perfect analogy on the role of a feeding tube.
Okay.
And I think she's freaking brilliant, right? This was Erin's analogy. And Erin, I'm totally botching this, but girl, I'm trying to do it justice. Okay. All right. She said you would never ask a physical therapist or an occupational therapist to move a patient without the safety belt, whatever the thing is you put around their backs. I don't know what I'm talking about there, but you know what I mean. And you would never teach a person who has had a total knee replacement to get up and walk without a walker, right? That's the purpose of a G tube or a feeding tube. It's an aid to get them somewhere. And I thought that was the perfect analogy. And but what is that belt called aside from safety belt? Because I can't remember.
You're talking. See, we told you we don't have a PT in our center. If we did, maybe we'd know.
I do. It's a gate belt.
There we go.
I'm like,
What is it?
Gait, GAIT belt.
A gate belt. Okay, gate belt sounds a whole lot better than safety belt. So there it is.
I mean, safety belt works too.
But yes, you're right. Okay, all right. So they don't have to have, because that's another misconception, is that I think and feel like before, especially because we don't have it in South Carolina. We're so hypersensitive to the fact that if we send somebody somewhere, most of the time the families have to pay out of pocket, even with like assistance and grants. It can still be several $1,000s. And so the fear of not knowing the etiology before they get there and not having a successful experience because they're still trying to chase out the medical that's a legit concern. But you're changing my triangle here. I'm loving this. Okay.
Yeah.
All right. So then
Well,
who
and go ahead.
no, go, because I was going to go to the next question, but go.
Okay. I was just going to say, and don't get me wrong, we want to look and see what's going on, and having our
Mhm.
medical colleagues involved is important. It's just sometimes there's just not anything, there's just not an answer that you're going to find, and that shouldn't prevent somebody from engaging in therapies to help them. Right. So
Mhm.
we want to make sure we do our due diligence, but once we've done the best we can with that, let's get moving.
Right.
Mm. Okay. All right. So then who benefits? Who's the ideal candidate for a combined treatment program? Because I know that in, I think it's CHOA has one that's specifically geared towards children that have autism spectrum disorders. And, we all hear rumors on the wind that, oh, you don't want to go to this facility. You want to go to this facility because they specialize in this. But I mean, like, you know, rumors are, they're just that. So, like, help.
So, I mean, to answer your question, I think that I don't want to narrow it down to like certain conditions. Um, I would rather look at more characteristics, um, so if you're looking at just a kind of a combined treatment session between a feeding therapist and psychologist, I think the big part would be a kid who obviously has, oromotor and swallowing issues and concerns, along with behavioral concerns. That's really the simple answer, kind of for that. If you're looking at kind of the big picture and looking at an intensive program, or how referring to like or even our evaluation clinic, what I usually tell new feeding therapists that I'm mentoring is if they have more than more than two kind of areas that they need help in. So if it's oromotor behavioral, if there is some sort of medical stuff, kind of like what we were talking about from a motility standpoint, vomiting, if there's weight issues, and it could be either weight gain or weight loss, kind of issues, along with a feeding tube, kind of placement, that all of those kids would benefit from a combined, kind of treatment, because you're going to need to pull as you work on the oromotor skill components, and you're working up on volumes of food. I'm going to need to rely on my dietitian friends to go and help me tell me how much of that feeding I can take away, because I can only get skill um, building so much before I run into volume issues.
Mm-hmm.
And I can't adjust tube feedings as an OT. Like, that's not in my scope of practice. So
Nor
that's
is it in an SLPs. And
correct.
I have had physicians tell the parents. I have one case right now, bless him, cutest little blonde-haired, blue-eyed kid ever on Thursdays. And the physician told the parent that I was responsible for it. And it was my job, that it was my fault that his tube feed volumes didn't increase. And I was like, oh, so that's inaccurate information. And here's why. And yeah.
And I feel like if you've been in the feeding world, we've all been approached by a parent has come to us and said, our physician has said that you would be the one adjusting tube feedings, and realistically speaking, the only person that should be coming from is either the physician themselves
Mhm.
or our lovely dietitians. you know.
There's a lovely dietitian who informed me that she has tits and not C's. So when you're spelling dietitians, make sure you don't add a C in there. And I thought that was great.
That's awesome.
You know what? I'm not going to be the one to tell that joke here. Oddly enough. It's funny how that works.
It's all right. You got a couple of double X's. We got you covered, my man.
It's 2019. All right.
Yeah. Oh, that's awful. Oh my goodness.
But I think if I go back to the original question too, I think what we were seeing a lot of in psychology is we were getting bombarded with all these referrals for kids who, um, what they need is oral motor feeding therapy. Like they do not have good chewing and swallowing skills, but they won't even enter the office or sit in the chair or, God forbid, let anybody's fingers near their mouth. And so it would be, well, can you refer them to psychology to work on the behavior and then refer them back to therapy to work on the skill? And what we found is that oftentimes just doing a couple consultations and being able to um, give permission for, this session might have a temper tantrum, but our goal is just to sit in the chair, and that's really the only goal. And if he pitches a fit for 20 minutes, that's okay. We're going to hang out, and somebody to help with how small of a goal to start with, what kind of rewards we're using, and how we build up. Sometimes I'd go over for a session or two, and then they would be able to put a plan in place, and then they're able to get to the part that as a psychologist I can't get to at all. And so it's these kids where, or maybe they're clamping their mouth shut, or um, also they'll do well in therapy, but then that doesn't translate to home. How do we navigate some of those more behavioral aspects? And then I think on the other side, we'd often do co-treatment sessions where I might call Beth or one of our other therapy colleagues over because, okay, I've got him eating his purees. I know that he, needs to advance to the next step. Do I need to send him all the way to feeding therapy, or can you tell me the next texture we can work up on volume wise? And we'll do that for a few sessions and then get another consultation. So, it kind of goes in both directions.
Oh my goodness. I Are y'all sure you don't want to move slightly warmer? I'm just saying.
I think about it in the
Yeah.
wintertime every year.
Yeah. There could be snowbirds,
Yeah, because I mean, it's all right. I think about moving come June through August when I'm like go outside and you get like a second shower just by walking outdoors with the humidity. So, I realize how neglected I've left my children when they have no concept of how to make a snow angel or a snowman because we've literally never had snow their entire 7 years and 5 years of existence. And the best is when Bear
Could you make?
Bear lays on the carpet and he goes, "Look, I made a snow angel." And I'm like, "Oh."
I was thinking they could do sand angels.
Yeah,
Yeah,
there
but
you
then you
go.
bring sand in the house and yeah, that's a negative sensory experience for the mommy.
Well, I guess that's how we get you to come up to Ohio instead.
Yeah.
Is we got snow angels. We don't have mountains or ocean, but we got snow.
You do have a good argument. Okay, now but you did touch on one thing, that transition. Going from the inpatient to the home health. Those are really and I'm totally skipping 2 questions, folks, to go to this one because they brought it up. So I promise we'll go back to the other questions. But, you have a captive audience of predominantly outpatient clinicians and home health clinicians, and we are practicing in silos on an island, and sometimes there's no snow and only sand. So, like, what do we do if we can't get the kid to a clinic in order to set up co-treating and setting up a combined treatment program in our little areas? Can you give us your top 3 suggestions?
So, Michelle, I think I touched base a little bit on this in my podcast.
Yes,
Um,
ma'am.
talking about setting like clear expectations, setting smaller goals, so you want things to be achievable. So, and what I mean by that is, ultimately, we want them to be able to maybe eat an entire bowl of macaroni and cheese. But we might have to start where they accept just the teeniest, tiniest little bite of noodle. So you want to set things up so that you can build upon successes, with it. Um, and like when you say something that you really want to mean it, so if you say this is your last bite, that you really mean it's your last bite, I think would be kind of the things that jump out right away to me.
I've been guilty of that. And when my one little guy with my Cheerios, after both of our last conversations with both of you respectively, I
Mhm.
have made such a conscientious effort in my own practice to stop. And when I say 4 more, and then we're going to do, oh my gosh, what is that Bruno Mars song? Uptown Funk You Up, Uptown Funk You Up. I can't tell you how many
Say
times I've
what?
danced to this. That's his favorite song. So, like, whatever. I can't dance. I have no rhythm. And if you had 4 bites, we were going to get up and tell Alexa, play Uptown Funk You Up. And, we would dance to the song and then come back to the table and then we'd have 5 bites, but setting that realistic expectation. Yeah.
And it's hard, right? I'm not gonna lie. There are many times where we've said 4 more bites and you're done, and they gobble it down in 30 seconds, and I'm like, I wish I would have said 10,
Yeah.
but you didn't. So you got to end after 4, and then next time we know we can come back.
Mm-hmm. Mm-hmm. So realistic expectations, start small, make it measurable, and stay true to your word. And
And yeah, and I think the thing that I've seen in most of the time, like if I'm going over to a therapy office and doing consultation with it, is um the child starts to get upset, and then it's the MO is like, okay, well, what can I do to calm them down or to settle out this situation? And if we've tried, maybe a more child directed approach for a while, or we've done something else and we realize, okay, no, it's it's a just one lick, but we really need you to get to this lick. It's setting that goal and then sticking with it, even once that volcano erupts. And so most of the time that actually might not even happen in that session, but next time they know you stick by it, or maybe it's the time after that. And I think that's been the hardest thing for people to sit with is, okay, they're upset and we're just going to hang out like this. Right. And so I would never ask a child to come into my office on day 2 and eat a whole cheeseburger, right? Or anything like that. So that concept only works if we're setting a reasonable goal that we know that they can achieve. But if we are setting that reasonable goal, and and they don't have that internal motivation to just keep going with it, eventually, that's where the times that I've been consulted, it's those kids who've gotten to that point where they get right up to the edge, but we've been doing this for 9 months, and they just don't take the lick or take the bite or whatever it is, and being willing to sit there in that time.
Mhm. um, I have one little one that with his little bitty Yankee accent, he'll go, "No, Shell, you do it." And I cannot even do the vowels right because, like, the Northeast has hard vowels for this little redneck mouth. You know what? We did my boys told me, they were like, "Mommy speaks English and Harry Potter ease." And I'm like, "That's right. I can tell you every spell they cast in Harry Potter. Beyond that, no, I don't speak any other languages." But, like, he will fake cry, and it's the fakest cry I've ever heard. And I mean, and there's no tears. It's not even like they're like alligator tears or like fake tears. It's just a fake cry. However, what we found for that little guy, thank you to the rest of the team, and it was the medical team, uh, the severity of the constipation. And the more constipated the kid was, the more fake cry we got. The physical therapist came in and did poop taping because that's like a
Oh,
thing. Do you
I've
have
never
you
heard of poop taping.
Okay, I don't know what's really called, but, like, that's what mom and I call it,
Like
is like
some
poop.
kinesio taping?
Yes, and it makes the kid poo because they do it on, like, the baby's belly. Like, I don't know, we call it the magical poop tape, but if we do a magical poop tape, I don't get any more Yankee, "No, Shell, no," and we have bites. But,
I
like,
may
So
have to investigate my PTs and their kinesio taping for
yeah.
poop.
it's poop taping, and it's the most we do something amazing. Well, she's actually from New York, so, like, don't get all excited. She's definitely not
Learn.
a South Carolina girl, but it's poop taping. I will do a segue between you guys. I have her message and I'll have her explain what the poop table is. Yeah, but we had to be comfortable and sit through a couple sessions where he was really agitated that we were going to make him do it. And he wasn't like throw down crying. And that's uncomfortable for me. I don't like that. I'm a firm believer we should stay positive to neutral. But I mean, like, if there was a distraction or Sissy came in the room, he was totally fine and happy. I mean,
But so I think that's part of the misnomer, right? As the therapist or as the clinician, in that situation, we are staying neutral to positive.
Mhm,
But it's just we are willing to stay neutral even if you go negative,
mhm. Crucial
right? And so I
conversation.
think
Yes.
so those are our two only gears. The feeding program here is all about the party. We are the party where we're just sitting there boring, but that's always where we're emphasizing. So even if they go down that place, we're not following. We're just hanging out.
That's awesome. Okay. All right. So, how long have y'all been doing this? Let me go back because now that we've gone jump to the end, let's go back. Squirrel. How did you start working in this combined transdisciplinary model? And like, how long have y'all been going at this?
Yeah, I'm sitting here trying to do the math in my head. So, so when I moved to Columbus, I actually was part of the feeding clinic team that Rob was not yet part of. Um, and so I've been working with and at that time we had a different psychologist. And so I would do some occasional co-treats, with her, not nearly the frequency of what I eventually did with Rob. So I think I can honestly say I've been doing this for 10 years, kind of off and on, much more organized within the last 6 years, kind of with it. And I think that's roughly around the time that Rob ish joined team here in Columbus. So yeah, so 10 years for
Okay.
me.
And then my specialty, I'm a child and family psychologist, pediatric psychologist, and so my specialty in grad school is working with kids who have large temper tantrums and things like that. And from the behavioral standpoint, we certainly get lots of that in meal times. So I actually got hired here 7 years ago. I'd seen a handful of feeding cases before that, but that's when I started. And the job was really for 1/3 feeding and 2/3 other stuff, but what do you know? Once you start to show people we're doing feeding treatment and it's working, it quickly blew up, and that's been all I've been doing since quickly after that. So, Beth and I, we had started pretty soon after. We were both in the evaluation clinic together, and we would sometimes have overlapping patients, and then like pick each other's brains, and also, with the other people in the center, it might not just be psychology therapy, but be going back and forth. And so that's kind of what stemmed some of this. And then we started our intensive pilot 6.5 years ago. And that's when really all of a sudden we're putting our heads together 3 hours a day, 5 days a week for these patients. And it was definitely co-treatment boot camp for sure.
Okay. So, what are your biggest life lessons learned? Like, I love looking back on what I thought I knew that I was doing, and then in retrospect, I'm like, "What was I putting those people and their family through?" Um, so, like, I mean, Michelle's dirty laundry list is it's pretty extensive. So what is yours, friend?
um, I've got one loaded if you don't.
Go ahead.
Okay. So, well, so I think one of the biggest things is other centers I've seen and been a part of at times is just a family should not have to choose between two professionals' opinions. So when we're
That's
doing
great advice.
co-treatment,
Mhm.
then I've run into this with maybe other people just collaborating this on the outside or whatever. But if you're telling them, nope, you have to sit there, you have a timer, you have whatever, and the other provider is saying it has to be 100% positive no matter what, the two providers need to come to an agreement on some sort of middle ground or a plan that can work, so that this family isn't stuck in the middle because they just feel paralyzed. And we in our evaluation clinic here, that's what we often get are families who it's not just two providers, they've been to 5 different providers. And so if you were to come in and see what they're doing, you'd be like, well, why are they doing all of this? Well, they're doing it because this one person told them in the NICU to do it that way, and then their physician told them to do this, and then the therapist they had that one consult with told them to do that, and they're doing their best to pull it all together.
And
So I
and
think
then
that's one of
and then they get the home health nurse that says, "Oh, no, it's just a tongue tie. Cut their tongue tie for a 2.5-year-old
yeah,
that's not breastfeeding."
right.
Sorry, squirrel.
That,
Really
so
angry
that
Monday
didn't
last
work.
Monday.
Is that what you're saying? That doesn't always work. That's weird.
Oh my God. Wait. Okay, folks, let me be perfectly clear. Everybody should have a lingual frenulum. We do not need to go around and cut everybody's frenulums. Okay. Oh my God. Yeah. There's really Facebook pages dedicated to that. And the answer at the end of the page is cut the frenulum. And I'm like, no. Okay. Passionate soapbox. Squirrel. Okay. All right. So that's a very good one though. They shouldn't have to choose between A and B.
Mhm.
Yep.
Yep.
We should work on that for them. Then anything.
I'm going back and forth in my mind. So
Well,
I
give
guess
us one, then we'll bounce to Rob and come back for your second. How about that?
it's not nearly as articulated as what Rob gave you. So I guess I look back at kind of my dirty laundry and looking back at it is thinking that we always have to move along the lines of where they are developmentally. And what I mean by
Mhm.
that is I think sometimes like you really need to look at their oral motor skills and their swallowing skills with the textures that they're eating. And I think sometimes we get stuck on if it's a 3-year-old that this is what their 3-year-old should be eating, and not always looking at what the 3-year-old's oral motor skills are really like, you know. And
Mhm.
I look back to some of my early years of feeding and think, gosh, I should have brought that texture food back, and I probably could have made better gains. I wasn't reading the child's cue of saying, I'm not comfortable with the food that you're offering me because I don't know what to do with it. And then that led to some behaviors, kind of to it. Whereas if you bring that texture down to something that they're going to feel comfortable with, they're more likely to put it into their mouth and to be able to move forward and make progress. So I think that's where I'm at.
Yeah. I think with the two of us combined, I've always been more the foot on the gas kind of person, and then every once in a while, I've definitely pushed too hard, and so I would say, when combining those goals to kind of Beth's point, we've gained so much more by making sure we're moving forward, but we gain more by going forward slowly than by, oh, okay, great, now let's jump to the next one and jump to the
Mhm.
next one.
It's the journey. It's not always the destination because that's mine. We get hung up on where we needed to get there, that the go, 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 you know what I mean? That I would forget to enjoy the journey, if that makes sense. Like, there's so many little celebrations to be made. God, I'm such a freaking sap. But, like, there's all those little baby celebrations, right? And my biggest what I wish I could go back and, like, shake myself for, I went to a class, and it was a class, and it was awesome. I mean, at the time that I thought it was, and they showed how we are supposed to offer therapeutic trials of advanced textures and flavors and place the food in the child's mouth, and the kid's totally physically capable of feeding themselves. And wow. I did that until finally one of the moms was like, "Well, how come the kid can't feed themselves?" And I'm like, "That's a great question, and I don't have the answer for it." And so I switched gears and started working on the kid feeding themselves, and that opened up the floodgates for progress. And I've never looked back. And then I've taken more courses, and I'm like, "Why was I forcing food into this kid's mouth?" Because of one class. Folks, question everybody. Question everybody and everything. Message us afterwards. Question us, because if somebody can't give you the rationale behind why, well, then we have a worry, you know?
And that's what I would say is one of the biggest thing that this has changed about my practice too, is it makes you really think about what do you know based on the research or the practice, or what is just sort of a like practice that people
Yes.
do but we don't know. Because when you're working with somebody, you're constantly asking each other, oh well, why, well, what do you think about this, well, is this like the way you did that, whatever it is. But you have to really think about it and pull out those essential ingredients in a way that when you're just cranking out visits by yourself,
Mhm.
you don't have time to do.
What's and that's hard. I mean, that's honestly, that's where this whole First Bite adventure came from, because, like, I mean, I know I suffer from bouts of insomnia and stress and anxiety, and I've been, like, super honest, candid about it, not to mention all the ADD, ADHD, and, like, just general contrariness that is me, right? But having wanting the why and not feeling like I had the time to dedicate into the why, that's really frustrating because, sometimes I'll come across a quote unquote article and I'm like, yeah, but there's not actually science in there. That's just pseudoscience, and pseudoscience is not going to get us where we need to get to. Just say no to pseudoscience, right? Like, yeah.
Right. Oh no, and I mean, like you talked before about the Facebook pages with the tongue ties, and it's not just Facebook. I mean, there's
Everywhere.
you can find online articles to support just about anything,
Mhm,
right? So, but it's really figuring out what there's evidence for and
mhm.
whatnot.
And online parent support groups for about everything also.
Mhm.
Yeah, and some of those
Which
are
can be
awful.
great in some ways, but can also it's hard in those. I know when my wife and I had our first kid, like we would go on those baby forums and then we'd be like, well, what's real and what's not? Like, how do you make heads or tails? They're all these people are arguing in opposite directions, So we hope we can steer people in the right way,
Right.
but
Oh my gosh. I'm just there is we have lost a part of society where we cannot, if we have a difference of opinion, it immediately gets to the I don't like you. And did you guys see the
Mhm.
Ellen DeGeneres sitting next to
Yep.
President Bush
I
thing?
did.
And I was like, but she's so
Love
right.
it.
Be kind to everybody. And also, like, he just looks so slapstick, funny, silly, happy next to her. And I'm like, they make
Mhm.
each other laugh. That's wonderful.
Exactly.
Yeah,
Yep.
yeah, and I mean that's totally what I feel like we are here, right? We could just dig into our silos and be like, no, it's
Right.
behavioral, no, it's oral motor or sensory or whatever, or it's no, it's
It's
all these
all of it.
things, and we're gonna hit it from all ends.
Right.
Yes. Okay. So we covered a lot of grounds. Okay, my last question. The billing piece. How does that happen? Because, like, I know that's one thing that we get, and that's hard in home health. Like, certain states, early intervention programs will only reimburse for like a set amount of co-treatments a month, or like a quarter, or like whatever their state policy is. But, like, are y'all allowed to bill for co-treatments?
Well, so for our intensive program, we have a daily bill. So that includes not just feeding therapy and psychology, but everything: the food, the chef, the social worker, dietitians, medical, the works. On the outpatient side, what we've been able to see is that as long as the goals are focused on specific things that are relevant to the discipline, and you're spending your specific time targeted on that, then there's not pushback from the insurance companies, and they've been approved. And we've actually not Beth and I, but another psychologist and SLP here have been doing a co-treatment program where they see families for like a 6-week boot camp, and the SLP might be sitting with the actual child while the psychologist is working with the parent on how they apply this at home, how the strategies work. So they're in the session at the same time, but they're targeting totally different things or looking at the problem through totally different lenses. And so, as long as it is clear in the notes and how that's built, that hasn't been a problem. I think that the problem would be if you're sitting as a psychologist, if I was sitting in an oral motor feeding therapy session for 40 minutes, not talking about anything behavioral, not focused on anything else, sitting and listening, well, that I couldn't bill for, right? But when you're looking at different things, and you're targeting different areas and you're actively working on those, it's been great.
The caveat I want to say for that is at least I know for OT, and I can't speak up from a speech standpoint, Michelle, is that you got to look at your
State.
state's stuff, so
Same with psychology.
For the state of Ohio, that's what we can do.
Mhm.
I can't say that that's how it's going to be across the board in all
Yep.
of the states, kind of with it. And since OT, we can bill in units. So kind of to Rob's point of, if I'm in a session, kind of with him, and I did, maybe it was an hour-long session, but let's say that only during 30 minutes of that time I spent doing more of the oral motor part, I was only billing for the amount of time that I was actually doing the work, so I might be there for the entire hour, but I really only could bill for the half an hour because that's all the time that I did, because I spent more time going into more in depth from a behavioral kind of standpoint, or if it was a
So,
heavy oral motor time, then I would bill for the entire time, so kind of looking at it and weighing it out from, being ethical in what you're billing.
so then that gets to the productivity question.
Yeah.
Yep.
That
Which is a whole,
that is a question, Michelle.
whole new can of worms.
How long you got?
Okay, so then I'm not going to go there in the last 45 seconds. I'm going to say, Michelle, that's pretty interesting, and maybe next
Yeah,
time. How
yeah.
about that?
Yep.
But what I'll say is that all that stuff has been able to find a way to fit in. It depends on the session, right? So the one that Beth was talking about, in that instance, it might only be 30 minutes of a session. But oftentimes, if it's one person's working with the parent, the other is focusing on the child, or vice versa, things like that, then that doesn't become as much of an issue. So it really depends on the specifics of the situation.
Exactly.
And just I can't stress it enough, even just a little bit of consultation either direction makes a huge difference. So, even if there were times where I'd be taking a productivity hit, if that's one time per month, but it's making a big difference, and then that's preventing another referral here and it's helping out this kid, I can handle that. Just couldn't do it all day.
And I second that. Absolutely. Because you got to do what's best for the child at the end of the day.
Yes, that's why we're here. Let's face it, y'all. We did not become therapists or clinicians to make the money. If we did, we would be lawyers. And I don't know, maybe then I wouldn't come home with so much frustration at the end of the day. I don't know. Do lawyers get angry? I've never met, like, maybe, I don't know. I've met some of
I
them
just spent an
lawyers.
entire weekend with a friend who's a lawyer who was talking about billable hours. So I think it's across the board.
Oh, really? Okay, well, that makes me feel so much better. You always think about, like, what's the perfect job? And, that's everybody's got their thing. Oh, my purse. Okay. All right. So, before we leave, a couple of thoughts just to put a little bit of joy out there. Y'all, Feeding Matters. I'm a huge fan of their nonprofit, in case y'all haven't picked up on that by now. They do have an annual scholarship for families that are trying to get into a aggressive feeding clinic, especially something that's out of state. So, if you yourself if you're not hooked up with them, then reach out to Feeding Matters. Always check out being their community ambassadors, because the Feeding Matters community ambassadors, they give you the tools to go out and actually work with the different disciplines, and might be able to help give you free information on setting up a makeshift combined treatment model in your immediate area. And then I had one other thought, and this is a shameless Skisha plug, but on Valentine's Day, which is only like 3 weeks away, y'all, we will be having the South Carolina Speech Language Hearing Association's annual conference right here in Coletown, South Carolina. And if you're not local, that means Columbia. So, and I live here. I think it's an amazing city. So y'all come and check it out. And, so there's my shameless plugs for the day. Go team. Yay. So Rob and Beth, before we go, if someone has any questions about how they can reach out to y'all for further assistance, are you guys okay with giving out your emails or a point of contact information?
Absolutely. Yep.
Okay.
So you can reach me. You want my email now?
Yes, please.
Okay, you can reach Beth at elizabeth.halpin@nationwidechildrens.org.
Okay.
Sorry, I had a brain fart there.
All right. And mine is robert.dempster, DEMPSTER, at nationwidechildrens.org.
Perfect. And I have to give a lovely shout out to Miss Hannah, who's the amazing first year grad student that saved my skin today when working mom probs. The husband got tied up in late meetings and she came and kept thing 1 and 2. So, there weren't any random people bursting in to beg for help unconnecting or connecting Legos. So, Miss Hannah, thank you. Because that's where we are in the world. Bear has learned to wipe his katukas, and now it's all about fine motors and Legos. So, yeah.
Thanks, Hannah.
Thank you, Hannah. All right, y'all, hold the line so I can switch over to questions, okay?
Okay.
Erin and I want to start with a really big, heartfelt first bite thank you. We have been so encouraged by your kind word, your messages, your glowing reviews of First Bite. This has been a labor of love for the last year and a half. And we are grateful for y'all being on the First Bite journey with us and supporting us because we work full time and this is a full-time gig on top of it. And we do it with joy because we understand that the world of early intervention pediatrics needs evidence in it. So we sweet talked the folks with speechtherapypd.com, and as a thank you giveaway, we have come up with a free podcast subscription. So once we hit 130 iTunes written reviews, we're going to pull another name out of the hat, probably with the assistance of an ever so handsome goose and a bear. And that person will get a free podcast subscription. That's our way of giving back. So thank you. So please keep the reviews coming. We only have a few more to go, but once we hit 130, then we will pull that name out of a hat. Happy 2020. Thank you for joining us on the journey. And seriously, y'all rock. Thank you. Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And, as always, remember, feed your mind, feed your soul, be kind, and feed those babies.